My name is Andy Allison. I'm the Director of Medical Services, Division of Medical Services at DHS. This is, to make sure you all are in the right room, the fourth Long-Term Service and Support Public Workgroup meeting. It is not only it's not just the fourth meeting associated with long-term service and support payment reform. We have meetings frequently, and you'll see a little bit of a time and schedule here in a minute. This work group is going to be a tag team affair. We have piped in from Ann Arbor a couple of the expert consultants that we have. Brant Fries and Mary James are under contract with DAS, with DHS to provide to us information on new payment models, also providing expert advice on and guidance and assistance in developing the universal assessments of need for the three areas, including long-term service and supports, developmental disabilities, and behavioral health as well. This is the team that actually helped create, or did create, the RUG system that Medicare also uses, so we're going right to the source and then to tailor it for Arkansas's purposes. So Brant and Mary are going to present the middle part of this presentation. Some of you have seen this before if you participated in one of the interim meetings that we had. So first, an update, long-term service and supports. We have just a little bit of context. Together we've identified a number of opportunities. We're not going to go through all of those, but a number of opportunities within long-term service and support for improvement. We've worked to understand where we are in long-term service and supports. Actually, this is the first time in a while that we will not be going through that same sequence of slides that describe the current system. The last group, we shared perspectives. We gathered input on key design elements, sort of the purposes, the goals, the aims for long-term services and supports. Of course, as you all know, and many of you have participated, there are interim opportunities for input to talk about data, to talk about methodology, and share ideas. And we've met any number of times, even since the last work group meeting here at UAMS, the third work group meeting. And so we're now ready to share some of what we have developed, initial perspectives on a future long-term service and support model. We've been very transparent all along the way of our intent to match the level of need to the level of payment, and more or less that means somehow case mix adjusting. It's the same concept, has different terminology if it's in long-term service and support, if it's in acute hospital reimbursement, but it's the same concept. Our objectives today to review the overall timing for these changes, to go over several key design elements. What are the different elements of payment? What is case mix? How would quality metrics work in Arkansas? How might those at a high level fit together to form the total payment for long-term to a provider for long-term service and supports? As always, we're here to gather your feedback, understand your perspectives. Please begin making notes for questions and comments and input. It's very important. We want to post, in addition to today's discussion, we'll be posting work group questions and answers on a regular basis on the website for Arkansas Payment Improvement, for the Arkansas Payment Improvement Initiative, and answer additional questions that are emailed to us, and there's an address there for you to send those. First, you'll see the period of time that we'll be collecting data for use in calibrating or choosing the amounts for a payment methodology. So there's the methodology, which is a formula, and then there's the data that feeds into that formula. And so this first item is the period of time that we'll be collecting data to feed the formula. And that really has already begun. We'll be drawing data from the present period into 2014 to calibrate payment levels once we have a methodology, and we want to make that clear so that providers know to collect data for this purpose from the regular mechanisms like the MDS, for example, in a nursing facility, understanding that data could very well be used to help calibrate payment levels. Secondly, we're in the process of sharing details on designs, gathering feedback. That's what we're doing today. That's what we'll be doing for the next several months, essentially the rest of this calendar year. Once we have a basic design, we will start feeding it with data and continue this iterative, interactive process of seeing the potential result, gathering feedback, seeing the potential result, tweaking, etc. And that extends well into next year. The first phase of a new payment methodology across the Payment Improvement Initiative is to begin by sharing information with providers on new payment levels, typically starting with the hypothetical. What if you already got paid this way? For your present clients, this is how much you would get, etc. So informing providers by way of beginning the reporting even before the payment mechanisms take hold. As part of any of the payment reforms, we're currently need to go through a promulgation process that is regulating this, sort of writing the rules and getting those rules at least reviewed by the legislature, a couple of committees at the state legislature, and you can see the time frame for that. And we target next July, a year from now, as the go-live date for new payment mechanisms for long-term services and supports. So the question was, nursing facilities are required to collect and do collect MDS data, information for their residents, and that's the information that we'll be using to calibrate payments for nursing facilities. Other types of facilities or providers don't use the MDS, and for them we are relying on new data from the Universal Assessment of Need, which is by design entirely consistent with the information that we can gather from the MDS. In fact, Brant, Fries, and Mary, they developed the RUG system for the MDS, and they can be used consistently. That's the whole point, is that we can have a consistent set of information and tiering of need, etc., that can be used for both the institutional and the non-institutional setting. We have information from that was originally used to calibrate the universal assessment. We, to the extent we can collect new universal assessment data between now and the time that we would set payment thresholds, we would use that universal assessment data as well. Some will and some won't require a change in our either waiver or state plan approvals from the federal government. So that's broadly speaking, we include that in the promulgation phase of this.
Does that fall in this timeline?
In the promulgation phase. So we typically want state review and federal review to be fairly close together.
Up on your period of time where MDS data may be used to set future payment levels, is that for nursing home and for home and community-based services both?
It's for the nursing facilities. Do the HCBS, do they collect MDS data? So it's only for the facilities who collect that data that it's relevant.
I was just wondering, is the January date the same for the home and community-based service providers? The January 2014, where the promulgation and the reporting delivered to providers for new payment model?
In that quarter is the target. We are wanting to as much as possible, to synchronize the policy development, the payment methodology, the calibration of payment levels, and the promulgation as we head towards next July, going live with both. Again, we've always viewed this as a continuum of services, and so that necessitates a continuum of consistent information about the need for services, the universal assessment and the MDS, which are consistent with each other, then leading to a payment for that continuum, which is also consistent.
Will there be a preliminary report to the facilities to let us know where our residents, and within nursing homes, where they stand in the payment system?
Yes. So at least at the reporting phase, so the 1, 2, 3, the fourth row, the fourth item on this chart is essentially the answer to your question. It's the reporting to providers of the levels of care and the payments that would exist, the quality metrics, all that we know about your facility, or if you're not a facility, for each provider. It's the preliminary reporting even before the payment methodology is changed and goes live. We already do this now for each of the medical episodes. We tell providers how they're doing before we actually implement the change and go live.
Using assisted living as an example, they have an annual review. So it's only 5 or 6 months to January, so many assisted living residents will not have a universal assessment in that time frame. How will that group be included in your analysis?
Right. So in the case of non-nursing facility-based care, I get some feedback about my use of the term institutional, residential, et cetera. Community-based nursing homes are in the community. The data that was used to help calibrate the universal assessment in the first place, the levels of care, was based on Arkansas data. So we already have information essentially relying on that same instrument from assisted living facilities in Arkansas now. To the extent that we can collect new information and use it to help further inform those payment levels, we will do so. But we already have an assessment. We have a pool of individuals, their costs in the Arkansas Medicaid program, their scores on this universal assessment, and it's the relationship between those two which will be used to calibrate the payment levels. So we have data. We will attempt to collect new data. We don't need full universal assessment results from all of your residents in order to figure out how much to pay.
So if I'm reading your graph correctly, and I'm not, we can expect the quality measures to be determined in August of this year?
Well, so this afternoon, we're discussing some proposed quality metrics, and we'll continue to refine and hone as we get feedback over the next few months. So yes, I think the answer is, this fall we will assume that that we have settled, and we'll move to the sort of calibration and calculation phase of this as opposed to the policy design phase. We haven't set a target date for review in the legislature by those committees. We have not yet set a target date for submission to CMS. The CMS rule is that the state plan amendment be submitted no later than the end of the quarter in which the payment change actually takes place. So CMS's deadlines here are not really an issue, because if we wanted, for example, to make a change effective next July, if we chose to, we could wait until September 29th of next year to submit the state plan amendment and make the change retroactive to July 1st. We are not going to do that, but that's actually the CMS rule. The more binding constraint for us is to get legislative review of this in advance of the change, which we'll certainly plan to do. And that usually takes about 3 months start to finish, when you have the comment period and then the committees which meet in sequence. Going to need help with that one. It's certainly the Public Health Committee has been reviewing these. The Rules and Regs Committee, is that right? Also reviews them typically in that order. I suspect with changes of this magnitude that those may not be the only two committees we end up providing information to, but those are the two involved in the formal review process. Question was whether ICF, intermediate care facilities, are included in this timeline. The ICFs are not included generally in this tranche, this category, the long-term service and support grouping of payment reforms. That would be through the developmental disabilities work groups that any changes in payment to an ICFMR would be included. And I would defer to Charlie and to that work group for the plans. I'm not up to date on expectations for ICFMR payment.